Congratulations. So how did you find the quiz questions today? And shall we start discussing? Okay, let's wait for a few more to join. Okay, so let's start with the first question, which is talking about a 53-year-old male is diagnosed with ocular hypertension. His progression to POAG may be best monitored on. So right now he has ocular hypertension, which means only his intraocular pressure is raised. What about his criteria for glaucoma? That is optic disc changes, then visual field changes and RNFL thinning. These are not present. So how do you monitor? So one of these things. So either we should be able to document optic disc changes compared to his baseline, or his visual field defects progressing, or RNFL thinning progressing, okay, on OCT. So what are the options given to us? One is ocular response analyzer, and option B, Goldman applanation tonometer, Goldman perimeter and Humphreys perimeter. Now, see, the rise in IOP has nothing to do with progression of IOP. Monitoring the progression of definitely you have to decrease the IOP, no second thoughts about that. But the question is very specific, his progression to POAG, meaning his actual diagnosis of glaucoma, how will you make? Definitely not based on ocular response analyzer. See, ocular response analyzer is going to give you your intraocular pressure again and corneal hysteresis measurements. So that is not going to influence your treatment decisions at all. Second option, Goldman applanation tonometer, which most of you are marked thinking IOP is the deciding factor for diagnosis of glaucoma. No, diagnosis of glaucoma, IOP is just a risk factor. Okay, so no, not at all. So again, not at this tonometer. Goldman perimeter. Yes, it is used to chart the visual fields, but monitoring of glaucoma progression is best done on automated perimeters with softwares. So that is Humphreys perimeter, which only 8% of you, the least number, have marked. Okay, so Humphreys perimeter is used for the monitoring of glaucoma progression because we have a progression software, okay, so which can compare it with the baseline visual field and tell us. So previously when we diagnosed the patient with OHT, ocular hypertension, the visual field was normal, and let's say after 6 months or 1 year when we are repeating the visual field and there is some visual field changes, the software will tell us, it will show us the progression. Is that clear? So the question is very, very clear, and please understand this concept. IOP, intraocular pressure, is not at all a factor to diagnose glaucoma. So already we have a diagnosis of OHT, ocular hypertension, which means his criteria for glaucoma. What are the criteria for glaucoma? Repeat after me. Number 1, characteristic optic disc changes. Number 2, characteristic visual field changes, defects. Number 3, RNFL thinning. Yes? So the question specifically asks about progression of OHT to POAG. So one of these 3 criteria we have to find out. So in which case the first 2 options are talking about IOP monitoring, so definitely ruled out. And Goldman perimeter, we can't really monitor glaucoma progression, I mean, as easily as Humphreys. Humphreys is like it's a ready-made output that you get. All right, okay. Now, because that was a true or false question, if you remember in one of the INI-CETs previously, there was a question where one of the options were glaucoma progression is monitored on, assessed using, I don't know, it is Humphreys perimetry or Goldman perimeter. So it was a true or false statement, so I've just used that to give you a new question. Alright, now let's move to the next question. Investigation of choice for serous retinal detachment. Most of you got it right. See, serous retinal detachment is characterized by subretinal fluid, SRF. So to look at SRF, yes, we can use ophthalmoscopy, you can see it on indirect ophthalmoscopy, but investigation of choice, even very minimal SRF can be found out on OCT. Okay, so OCT is the investigation of choice for serous retinal detachment. Most of you got it right. See, all the 4 options. Indirect ophthalmoscopy, you can see the SRF. B scan, yes, you can see the SRF, especially when it is massive. The serous retinal detachment is massive. FFA, again, you will have pulling of dyes, but investigation of choice, that means a very sensitive investigation which can pick up early ones. Yeah. Good evening, Dinakar. How are you, pa? Long time. Are you that old Dinakar I know? My Facebook wala Dinakar? Okay. Now, a patient sustained, third question, a patient sustained blunt trauma to his left eye and has sudden painless decrease in vision and left-sided RAPD. RAPD means relative afferent pupillary defect. What is the first investigation this patient needs? Okay, now this is kind of a little vague. Oh, good, yeah, how are you? I think you joined PGIO edo alla? Pondicherry paiyan thana Dinakar. Okay, so option A, B scan. Now, why would I want to do a B scan? I don't have any diagnosis in mind. So there's a sudden painless decrease in vision, left-sided RAPD. A B scan, okay, question mark. Okay, so we'll revisit that option. CT scan. Now, CT scan, I want to look at the bones. This, okay, blunt trauma, I could have had blowout fracture, but there is no other thing suggestive of blowout fracture. They've given us sudden painless decrease in vision. Blowout fracture itself will not cause a decrease in vision. That will definitely not cause an RAPD by itself. So CT scan most likely 90% ruled out. Although B scan I'm still keeping in mind because I don't know what they're trying to say. Ophthalmoscopy, okay, that means I want to look at the fundus, probably yes, because when there is an RAPD, I know there's an extensive problem of the retina or optic nerve. So I want to look at the retina or the optic nerve. So yes, ophthalmoscopy 95% I feel like it could be ophthalmoscopy. Tonometry, why would I want to measure intraocular pressure? First, next investigation or the first investigation, this patient comes to me to the OPD on the emergency, sudden painless decrease in vision, and when I check the pupil, initially cursory examination with a torchlight, I say RAPD. What would I want to do next? Do I want to check IOP? No, I don't have any diagnosis of that sort. Do I want to do CT scan? No, doesn't look like blowout fracture because I've not been mentioned any of the findings in the question. I can't assume, are blunt trauma hai, ohi hua hoga. No. Is it mentioned in the question in ophthalmos, anything about the eye movements, any subconjunctival, not even subconjunctival hemorrhage, nothing is given, no image is given. So now relate your RAPD and your sudden painless loss of vision. So something in the retina or something in the optic nerve, blunt trauma. So it should have either been central retinal artery occlusion, yeah, your not your central retinal artery, your Berlin's edema, commotio retinae with cherry red spot, or it should have been an optic nerve avulsion, something of that sort. So that is why there is an RAPD. So now no use for B scan. B scan say jata nahi, at least not the first investigation. First I should make a proper diagnosis now. And I've got an option, ophthalmoscopy. So basically I need to do a fundus examination. So fundus examination could either reveal a commotio retinae, I do not know. It could be a commotio retinae. What is a commotio retinae? Commotio retinae is a combination of your Berlin's edema. What is Berlin's edema? Another MCQ. Berlin's edema is a retinal, milky white retinal edema that you get after blunt trauma. Somebody hits you here, you get a blunt trauma effect on the retina along with cherry red spot. So the patient can again have RAPD in this case, okay, or avulsion of the optic nerve, because we don't know what kind of blunt trauma. It could have been a decelerating road traffic accident where the optic nerve avulses, okay, so it retracts, and in that case also you can have, or it can be just a traumatic optic neuropathy because the entire shock. It can be the pressure around the optic nerve in the optic canal, which is compressing the optic nerve, causing traumatic optic neuropathy. Again, you'll have a sudden painless decrease in vision and RAPD. So these are the three probable differential diagnoses which will need a fundus examination. So did I do a marathon breathless conversation monologue? All right. So understood the third question. A fourth question. All of the following are true regarding direct ophthalmoscope except. So option A, monocular. It is a monocular instrument. We hold it in one hand and you see through one eye, so that you don't end up smooching the patient. Right eye of yours looking into the right eye of the patient, and left eye of yours looking into the left eye of the patient. Okay, and be careful of all these perverts. Don't go very close to them. In that case, do a slit lamp or an indirect ophthalmoscopy. So direct ophthalmoscope done very close to the patient, and it is a monocular instrument. So when it is it's a monocular instrument, there is no stereopsis. So option C is also correct. Real and inverted image. Guys, real and inverted image is a feature of indirect ophthalmoscopy. Indirect ophthalmoscopy, you get eye. Yes, eye, inverted image. Real images are always inverted. Direct, you remember Dev. D-E-V. Dev. Devdas. Dev. Or Devta. So direct ophthalmoscopy, you have an erect and virtual image. Good evening, Ma Sivasangari. How are you? We'll discuss refraction one day. Okay. 2-3 days later, we'll discuss, Ma. I saw your message. And 15 times magnification of the image. Yes, it's good. It's got a very good magnification, direct ophthalmoscope. So that is why For beginners, because beginners, when everything is big, you can easily make out the findings rather than small, your mind has to be used to it. So the answer for this question, all are true regarding direct ophthalmoscopy, except will be that option which says real and inverted image, because what kind of image we get in direct ophthalmoscopy? We get a erect and virtual image. Hi Pavan. So Pavan said hi. Hi Pavan. All right. So question number 5. On retinoscopy, a scissoring reflex is seen by optometrist, because optometrist is the first person point of contact, then comes to the ophthalmologist. So what is the investigation you want to order for this patient? Because most likely the optometrist will either give you a call or come running to you saying, I saw scissoring reflex. So what you would want to usually do is, even before you see the patient, you would convince the patient to get a op scan done or a pentacam done, a corneal topography done, because scissoring reflex, think of keratoconus. The earliest clinical sign of keratoconus is scissoring reflex on retinoscopy. So when you do retinoscopy, the streaks will keep moving like this, and especially when you move your instrument, you rotate your instrument, it will keep moving like kanchi, okay, like the blades of a scissors. So that is the earliest sign of keratoconus, and most likely the ophthalmologist will not see it because the optometrist is going to do the retinoscopy. So you get a corneal topography done, a pentacam or an op scan. Now, the word corneal topography is not here because you want to diagnose keratoconus. What is the investigation of choice for keratoconus? Corneal topography. But I am looking for corneal topography. But I am so chalak, and I'm so cunning and very sadistic. So I have given you video keratoscopy, I have given you B scan, OCT, A scan. OCT is for posterior segment. A scan, not going to give you anything for keratoconus. B scan, nothing to do with keratoconus. So actually what is your corneal topography? It is a keratoscopy. You're looking at the cornea. Scopy means to see. Kerato is cornea. Video keratoscopy. So all these pentacam op scans, these are all video recordings, and then you will get snapshots. Yeah. So video keratoscopy, because that is the other name of your corneal topography when you read certain textbooks. So I've just given the other name, video keratoscopy, but commonly called as corneal topography. In probably some very theoretical setting, we call it video keratoscopy. Okay, so you should be prepared to that. Hey Jalal, எப்படி இருக்க? வணக்கம், நல்லா இருக்கீங்களா? எப்படி இருக்காங்க உங்க வைஃப்? நல்லா இருக்காங்களா? ஏய், கிளாஸ் நடத்திட்டு இருக்கேன், சாப்பிட்டாச்சான்னு கேட்குற? இல்லை, பையன்மேல் தான் சாப்பிடணும், இருந்தாலும் உனக்கு ஏது ஓவரா தெரியலையா? சீரியஸாக கிளாஸ் எடுத்துட்டு இருக்கேன். உன் பெருமாள் இப்போ வந்து பூஜை ரூம்ல இருக்காரு ஜலால். ஐ ஹோப் யூ ஆர் டூயிங் வெல். சரி, ஓகே. நெக்ஸ்ட் கொஸ்டின். Berkey's method is used to. This is a very split answer. You guys didn't know. See, Berkey's method is a clinical method to measure levator palpebrae superioris ka function in ptosis assessment. So whenever you are assessing a case of ptosis, always you have to measure LPS function. So how do you measure Berkey's, how do you do Berkey's method? So this is for the third years and the PG postgraduates who are watching this video. See, normally you ask you stabilize the head against a wall or a fixed hard board so that patient doesn't move his head, and sometimes patient might even have a compensatory head posture. So you correct that and then fix at the eyebrows with either your thumb or your index finger strongly. Okay, so that is to negate your action of frontalis muscle, which is an accessory muscle of lid elevation. There are two muscles of accessory muscles for lid elevation. One is your Muller's muscle and frontalis. So you don't want the patient to overarch his eyebrows and act using your frontalis. So after that, you ask the patient to, you done this, ask the patient to look down. You show a target completely down. Now use a transparent scale to measure. So you keep your zero measurement or whatever, you know where you're starting, and then ask the patient to follow your finger till complete up gaze. So now on the scale, you see how much the eyelid has moved. So LPS excursion, upper lid excursion from down gaze to up gaze. So that is Berkey's method. So we are going to measure LPS function. Girl baby, hey, congrats, yeah. God bless you, Jalal. May God bless you abundantly. You, your wife and your kid. So happy. Yeah, but WhatsApp message panla. WhatsApp message panirka nama. So happy, guys. Really happy. Invite me home, okay? I'll come home someday. Now, this image. And this image is a little tricky. You may not know what this is. Okay, so it's touching the eye. Okay, now one of the options was Schiot's. Now you all have seen Schiot's. So this is definitely not Schiot's. So it's ruled out. It's definitely not Schiot's tonometer. It's one old looking, ugly looking instrument. It's not as fancy as this. Specular microscope. See, specular microscope will be a machine with a desktop, one desktop machine it will be. It will have a board and yeah, good Pavan, very good. It's tono pen. Okay, and it will have a stand, and patient will keep his chin on that. It's just like one of your corneal topography. It's just like one of the machines you go to an ophthalmologist. You see a balloon and all that. Like that only that machine also will be. See, you can't differentiate just by looking at the machine from outside. All same. All Ophthal machines will look the same. Okay, at least for a layman. So specular microscopy will not look like a pen. Okay. Then tono pen was option C. Option D, esthesiometer. Esthesiometer I've shown you. Yeah, it will have a nylon filament. Where is the nylon filament? This is almost going so close to the eye, and that esthesiometer will usually be black in color. Okay, this is just like a pen, and you'll get a digital reading here. A digital reading will come out here. This is a tono pen. Okay, very good, Pavan. This is tono pen. And Kothari, yes, Dr. Kothari, tono pen. And question number 8, investigation of choice for retinoblastoma. Guys, it is MRI. It's a close call. Looking at the percentage of students who replied, who answered that question. Thank God nobody said OCT. Now, why not CT and why is the answer MRI? The answer is MRI of the brain and orbits. See, you can do CT because you all are thinking, ma'am, calcification is there, so you want to do CT. But my point is, for 2 reasons we do MRI. See, practically we might do CT because it's more cheaper than for the patient, so it's affordable and all that we can repeat. But the point is, ethically speaking, one, CT is having a lot of radiation. Okay. Now, when I have a patient with retinoblastoma, I do not know whether the patient is a sporadic case of retinoblastoma or a hereditary or familial retinoblastoma. See, these hereditary retinoblastoma have a high risk of developing osteosarcomas and other malignancies. And exposure to radiation will increase the risk of developing such an osteosarcoma. Yes. So, see, this day, all our RB patients survive. The survival rate is extremely high. In fact, even their vision remains. So now, when the patient is surviving for long periods, I don't want this patient later in life when he's 20 or 30 to get an osteosarcoma and die because of osteosarcoma because I did CT for the patient. Yes, so CT is avoided because exposure to radiation increases the risk for second malignancies. Number 2, advantage of MRI over CT is MRI can pick up the brain metastasis, even minimal metastasis into the optic nerve, because my treatment of algorithm will completely change if there is evidence of metastasis. And also, if it happens to be a hereditary retinoblastoma, there might be a pinealoblastoma which an MRI will pick up, not a CT. So that is the idea of doing MRI of one shot. You do orbit and also combined with the brains. Dinakar, illappa, idu the explanation. Okay, see, textbooks will not give you CT. Practically, yes, we do CT, but this is the thing you do. You prefer MRI. Yeah, I think I've made myself clear here. All right. Now, question number 9. Angle kappa can be measured by. See, angle kappa is the angle between visual axis and pupillary axis. Now, in this video, there is no scope for me to explain angle kappa. That I'll do in a separate video. Okay. Now, angle kappa can be measured on synaptophore. Okay, it can be measured on synaptophore, right? Okay. Now, so that is the answer. Not Maddox rod, not double Maddox, not Maddox wing. Now, this another image-based question. So, this is duochrome test where the letters are written in black, one against a red background, another against a green background. What is the principle behind this test? This is chromatic aberration. Okay, chromatic aberration. I will discuss this chromatic aberration properly in another video. Okay. So the options here were pinhole effect. No, not at all. There's no pinhole effect. Patient sees this and reads. That's all. So he will read both the sides and he will tell us which is clearer, whether the red background is clearer or the green background is clearer, and then we will do the balancing. Okay. So it's basically for refinement of refraction. Okay. It's basically for refinement of refraction. Duochrome test. Duochrome. 2 colors are there. Chrome means color. Duo means 2. And spherical aberration, no. This is chromatic. Has to do with the color. Okay. And crowding phenomenon, definitely no. Those of you who mark crowding phenomenon, very bad guys. One quiz I told you crowding phenomenon has something to do with amblyopia. This has got nothing to do with amblyopia. So duochrome test is basically a test to refine your refraction. Yes, refine your refraction and for binocular balancing as well. Yeah. So that completes today's quiz. Oh my god, we've taken 20 minutes. All right. So any other questions? என்ன தினாகர் ophthalmologist என்ன நிறைய question கேக்குறீங்க? எப்போ பிஜி முடிச்சிட்டீங்கல? What specialty are you in, Dinakar? What about the others? Any other questions related to today's questions? Because today's topic was pretty vague. Not vague. It's a vast one with no particular syllabus to it. So do you have any other questions regarding today's? Oh, where are Dinakara? Okay. Saripa. Hi, who is this? Moni Shakti. Hello. Okay, Dinakar, right. What about can you suggest on the books? Read Parsons. Parsons is a standard textbook. Oh, post-intern, Dinakar. Okay, I confused you with another old student of mine. That's why I was asking. See, so now that means your post-intern for you MCQ. It's MRI. MRI is the investigation of choice. Karura, okay pa. MRI of the orbits and brain is the investigation of choice for retinoblastoma, and you know the logic, the rationale behind it. So now no mistakes, the controversy or whatever it was, it's over. Okay. All right. Any other questions, guys? Any other questions regarding today's questions? Any other doubts that you have? Is it clear? Or did you have any other doubts regarding today's quiz questions? Kal ka kya hai? Kal ka tomorrow's is IBQs, is it? I just don't know. I just keep forgetting. Okay, so join the Telegram group, please. That's what I told, na Kotari. I'll explain duochrome test in another video proper. Okay, I'll explain only duochrome test so that when you want to come back and watch the video, suddenly you want to say, okay, what is duochrome test? It'll be easy for you to come back. Otherwise, you'll be searching, someday she said, where she said, when she said. Okay, that's the only reason why I said I'll do it in one of the coming weeks. Definitely before your INICT exam. Okay, trust me on that. I've noted it down. I'll write it down and keep it so that I will explain it to you. Okay, and tomorrow we will meet live at 5 p.m. We will discuss one more new drug. Yeah, sure. Kotari, I'll not go back on my words. Tomorrow clinical scenario. Okay, good. Hi, who is this? Prajwalit. Hey, Prajwalit, good evening. How are you? Long time, I know. Lovely to see your message, yaar. How are you? I know I love looking at your names, flashing like that. Good. How are you? Good? Okay, I'm also good. Lovely to see you here. Ping me, okay? WhatsApp में message कर लो आप लोग. Okay, I think there are no more doubts. I'm good, Prajulit. I'm good. I'm very good. Okay, so lovely teaching you all. So we will meet tomorrow 5 p.m. new drug. Okay, so see you. Oh, lovely. Ishak 4625 rank. Very good. Congratulations, beta. God bless you. Take ophthalmology. Okay. Okay. Good. Very good. Okay, so I'll take leave now. Namaste, all of you. Good night.